I'm going to be talking today about septic joint. I'm Dane, for all you guys that didn't meet me yet. So my objectives today, we're going to define what a septic joint is, mechanism and pathogenesis, speak somewhat about the clinical features, talk about diagnosis and treatment. So definition. So it's invasion of the joint by bacteria specifically, and after the invasion of the bacteria in the joint, you'll have the associated inflammatory process, which if left untreated will cause destruction of the joint. Septic arthritis is broken down into two categories, gonococcal and non-gonococcal, and we'll speak more about that. So it's thought to be spread through the blood, mostly, in most cases, but you can also get a septic joint from trauma or bites over the joint, or any recent joint surgery. After the bacteria enter the space, there's an inflammatory process that ensues, and cytokines and proteases are released, which cause the destruction of the joint. The buildup of too much of the synovial fluid as well can cause pressure necrosis. So non-gonococcal septic joint. So if you have a joint that is acute, hot, swollen, and tender, it's a septic joint until proven otherwise. And according to Margareton et al., in 2017, 80% of these people had those presentation. Other factors that you can also include is fever and chill, but those are less specific. And often the elderly, you don't have a fever. Signs of other infections such as a UTI or skin infections or a respiratory infection can also clue you into whether or not this is a septic joint going on. Gonococcal septic arthritis. So this is the most common septic joint in young adults and teenagers, and usually this presents, they have usually a prodromal phase where you can have like vesicles on the hands, or they have this migratory arthritis, which finally they settled on usually one or two joints, and in this case you want to get a sexual history. It doesn't cause joint destruction as much as the non-gonococcal, and the organism involved is usually Neisseria. So these are some of the organisms that are involved. It's not as great as I would like it to be. But staph and strep, you're going to see that in your young, healthy adults. Neisseria, like we mentioned earlier, you'll have like a prodrome where you get these vesicles, and you see these like in your sexually active young adults as well. In the immunocompromised, you'll have your fungi and your mycobacteria and Lyme disease. So they'll have that characteristic Lyme disease rash and exposure to a tick. So diagnosis. So from an ED perspective, it's the diagnosis not to miss on an acute joint. So it's pretty important to at least think about it and use your history and physical to either include or exclude whether or not you're working with a septic joint. Age, gender, and comorbid illnesses can help with the diagnosis as well. Studies to SEND. So SEND rate and CRP are going to be elevated in your inflammatory as well as your infectious joints. So they're non-specific.
What about sensitive?
Not sensitive really at all. Because they'll be, as far as what I read, they'll be elevated in your inflammatory, in your gout, in your septic. So I don't know that it's very useful when addressing.
But not specific, right? Like
Yeah.
True.
I think it's actually right. It's totally non-specific, but
yeah.
If you have normal white count, normal sed rate, normal serum,
true,
it's very unlikely that you have something normal.
True. Yes, so in that case, it can, I guess, help in your diagnosis. Other things you can send off are Lyme, RA factor, NAA, HLA-B27, which can help the guys upstairs, not so much for us. So the next thing is tapping the joint. So there's some relative contraindications to arthrocentesis. So if there's any overlying cellulitis, coagulopathies, prosthetic joints, these are some of the relative contraindication to tap in the joint. So normally you like to have the patient supine with their leg up. You're going to use one hand to stabilize the knee. Then you want to go down like midway Here we go. So then you want to go like midway down the length of the patella, and that's where you're gonna insert your needle. And after that, of course, you want to observe what the aspirate and everything looks like. And here, we speak about, we're going to see some of the results that you'll get back from that aspirate. So clarity and color can give you some sort of clue about what you're dealing with. Of course, if it's like purulent, you're more likely to think it's septic. The one the orthopedic doctors like is your white WBC count. So according to UpToDate, greater than 20,000 is usually diagnostic, or you can think more about a septic joint. But according to the orthopedic doctors here, they think more than 50,000.
It's interesting. Souf did a study, and he had a bunch of patients, and his study had white counts of 10,000 for septic joints. So,
exactly.
So there's a range, unfortunately.
And that's
you can't hang your hat on that.
And that's a good point, because if you have a high suspicion for a septic joint, but the numbers are not correlating with what you expect it to be, you should still treat, because within a week these patients can have destruction of their joint. Cultures. So they're often positive in the non-gonococcal septic joint, but with Neisseria, you're not usually going to get a positive culture. So treatment. So
How long does it typically take for the cell counts to come back this year?
it usually takes a few, yeah.
Yeah, it's like getting
It's
doing a CBC.
CSF.
Okay. So you will get it back on that same visit.
Yeah.
Yeah.
Everything way back except for the culture.
And let's go back to that. So yeah, so usually when you're sending off the aspirate, some of the things to think about are gram stain, culture, and of course crystals if gout is on your differential, and your WBC count.
But even if you have crystals, you could have coexisting
Exactly.
septic joints. So.
Good point again. So in terms of treatment, your treatment goal is directed towards staph, strep, MRSA, and Neisseria. And in that case, you're going to use Vanc and a third-generation cephalosporin, usually ceftriaxone. If the patient is pen allergic, you can use like the penoms, like imipenem. So just a quick question. 34-year-old female with no medical problems came in with a swollen, tender right knee with significant decreased range of motion. Which of the following is an absolute contraindication to tap in the joint? Anyone? Yes.
This is an absolute contraindication.
So the important word right here in the question is absolutely.
RTC.
So these are all relative contraindications, so the answer is not of the above. E.
But
Okay.
it's a prosthetic joint.
So according to Tintinelli, you still can go ahead and tap the joint even if the patient has a overlining cellulitis, because they listed this as a relative contraindication.
And generally, so if you have a prosthetic joint, you want to get ortho.
Yeah.
These patients, they also have very low white counts and still have septic joints. So, you know, the white count, the threshold is much lower for a prosthetic joint. And they probably have ortho, you know, to do that, for doing arthrocentesis on if they have prosthesis.
Okay.
So what if you're in a community and you don't have ortho directly? Do you send out, or do you like empirically cover?
I suppose that's a, you know, aberration where you might, you know, go ahead and do it, but in general, yeah, ortho would do it. And remember just that your white count, instead of being 20,000, it could be much lower. Yeah.
Any thoughts from the community people as what you would do in those situations? That'd be great.
I mean, I'd still most likely get ortho. Do it. Because you don't want to introduce anything.
If what you're saying, get
If they had a
It's not
prosthetic
available.
joint.
Oh.
Yeah.
All right.
So apparently, if you have an infected joint, a lot of times ortho is probably a good idea to touch base with ortho first before you give antibiotics, because sometimes you tend to just give empiric antibiotics, and a lot of times they want to culture the joint first to see what the bug is going to be for treatment in the future before you give the antibiotics.
Yeah, usually that's what I recommend, tapping before antibiotics is given.
Not like meningitis.
Right.
Yeah.
It's not really the antibiotics that are going to save the joint. It's the washout earlier.
Yeah.
In certain cases, in certain cases you actually don't need a washout. In the case of like gonococcal septic arthritis, you may end up not needing a washout because those cases are usually less destructive to the joint.
Do you know how many sets of cultures are recommended? Because I was talking to one of the ortho residents the other day, and she said they usually send 3. Do you know?
Yeah, I didn't read much on how many we should be sending.
They were saying they tap at 3 separate times.
No, they just take 3. They send 3 separate spots, or not. I mean,
Like in 3 tubes, like
Yeah,
they
with
just send. I mean, you send off as many. Like,
I guess-
like catch it, right? So you send off.
Well, it's
2
also
little,
for confirmatory,
right.
so you know it's
Yeah.
not contaminant.
Right.
And while the patient is admitted upstairs as well, they usually sometimes can go back and tap and see if there's any improvement in what's going on in the joint. And mostly the reason why we get ortho involved is for potential washouts, right? Because we can tap it ourselves, we can start our antibiotics. But the patient will need to be evaluated to see whether or not the patient is a candidate for a washout. Any more questions?